A very good afternoon, everyone. On behalf of CARDICON 2021, 27th Annual Conference of CSI Bihar Chapter, I welcome you all on the second day of this conference. And to start with, a fascinating session on cardiac imaging, where a galaxy of renowned speakers are going to speak on various subjects. And I request the chairperson and moderators to take over. I invite Dr. Arvind Kumar sir to take us from here through the session. Thank you.
Welcome you all in Hall B for the second day of annual conference of CSI Bihar chapter. We have with us 5 speakers of national and international repute. They are expert in their chosen field of cardiology, cardiac imaging, clinical cardiology. And to start the session, we have with us moderators, Dr. Prem Kumar, who is the head of the Department of Radio Diagnosis, AIMS Patna. We have with us Manish Kumar, is a senior echocardiographer, City of Bhagalpur. We have Nitish Kumar Ranjan, intervention cardiologist from Indira Gandhi Institute of Cardiology, Patna. And to chair the session, we have Dr. S.K. Shuman, head of the Department of Radio Diagnosis and Nuclear Medicine, IGMS Patna. The Rakesh Mehra from Patna. The Ansu Agarwal, a senior cardiologist from Muzaffarpur. Sisir Kumar Mishra is an intervention cardiologist from Heart Hospital, Patna. And the Binay Kumar from Begusrai. The first, I would invite Dr. S.K. Suman, our chairpersons. You please welcome and invite our first speaker, Dr. Ranjan Kumar from Patna, to start his session. Dr. S.K. Suman, our chairperson, please invite Dr. Ranjan Kumar.
Thank you, Arvind sir. It's my pleasure to be chairperson of first session related with the cardiology, CARDICON. I invite Dr. Ranjan Kumar, senior faculty in Medanta Hospital. His topic is coronary angiography versus conventional coronary angiography. Dr. Ranjan Kumar, please.
Thank you, sir. And first of all, thanks for giving me this opportunity to talk on this platform. I have been doing CT coronary angiogram for last 4.5 years. And today in 20 minutes, I'll be discussing about, first of all, I'm trying to share my screen. How it will be shared. Share screen.
Yeah,
now.
there must be a red. Have you started the PPT? Have you started your presentation? PowerPoint?
Yes.
Yeah. Now you can see.
Yeah. Are you people able to see my present screen?
Yeah.
Yes, it's okay.
Yes. Sorry for this delay. So in next 20 minutes, I will be discussing about CT coronary angiography versus catheter angiography. Where CT CAG, where does it stand in front of catheter angiography? I'll discuss in following orders. First, I'll talk about a little bit about the recent advancement in CT machines, which enables us to scan the moving heart. Then about guidelines and indications for CT-CAG. Then I'll talk about calcium scoring. Then I'll show few of my cases. And then eventually we will see what are the disadvantages of CT-CAG and what are the advantages of catheter angiogram, which enables this test still as a gold standard for coronary artery disease. So start with the recent advancement. For last 15 years, there has been tremendous advancement in CT scanners. And now we are able to scan the moving heart and millimeter size of lumen of coronary arteries. So in terms of what are those advancements, in terms of temporal resolution, that means the speed of the rotation of the CT tube. Temporal resolution means at what speed you can scan the image, you can scan the body part in one rotation of the tube in CT machine. So there is a significant improvement in temporal resolution, and now we have a very fast scanner. Another improvement is coverage. Regarding coverage, coverage means what centimeter length of the body part can be scanned in one rotation of the tube. So nowadays in 320 slice or more slices, now we can scan the entire heart in one rotation of the tube in single breath hold. So these are the advantage. Another big improvement is reduction in the radiation dose. Improve the fast scanner now. There has been significant reduction in the radiation dose. Now we can do CT-CAG with giving approx 2 to 5 milliwatt or lesser than that in very high-end machine. So now regarding in terms of radiation dose, we are now comparable with catheter angiography, and still technology is advancing. Now you can appreciate the image quality.
Could you please make it full screen slideshow? Sorry, slideshow.
Yes.
Yeah, thank you so much. Thank you so much.
Thank you. So you can appreciate the image quality and clarity of the resolution and images in different slices of the machine. So you can see this is the RCA, right coronary artery, in 16 slice. You can see the right coronary artery in 64 slice machine. And this is the image of our machine, that is 128 slice. This is a LED. So you can appreciate the clarity and resolution of the images with increasing the slice of the machine. So we have improved a lot in terms of resolution and speed. Other advantage of CT-CAG, due to multi-detector, multi-slice CT, we can reconstruct and post-process our raw data in a very different manners. Like we can have multi-planar imaging, we can have curved images, we can straighten the artery. You can see here the artery has been straightened. You can see the lumen of the endon lumen of the artery. We can have the volume rendered 3D images of the heart and coronary artery. So we can see the coronary artery from n number of angles. So these are the advantages of multi-slice, multi-detector CT. Now talk about guidelines. I'm not going into the detail of the guidelines, but 2016 NICE guidelines and European Society of guidelines of European Society of Cardiology said that CT-CAG is very effective clinically among all these tests in terms of high sensitivity and moderate specificity. And again, one advantage is it is very cost effective. It has lowest cost per correct diagnosis. So among these tests, CT-CAG stands ahead in terms of these advantages. So according to these guidelines, there are robust evidence base upon which CT-CAG is advised as a first line investigation in a stable patient who has chest pain due to it's a high negative predictive value. What does it mean? It means that if patient had CT-CAG and in the report, if there is no coronary artery disease, then in CT-CAG, then patient doesn't need to go for any further invasive test for coronary artery assessment. So this is the advantage of high negative predictive value. Other big advantage with CT-CAG is we can characterize the plaque. That is the morphology of the plaque, whether it's a calcified plaque, whether it's a non-calcified plaque, what is the plaque burden, whether it's a vulnerable plaque. We'll discuss later on in detail with in recent advanced machine, we can have FFR and myocardial perfusion in the same sitting without giving any extra contrast or extra radiation. But these are not so cost effective right now, but in future we will have this FFR and cardiac perfusion on CT scan. So based on all these guidelines and Scott Hart trial, they advocated that these are the indications for CT-CAG, that is the stable patients with suspected CAD, then patients with acute chest pain in NSTEMI category, pre-op evaluation for non-cardiac surgery. If assume that if one patient going for renal transplant and surgeon wants to have cardiac clearance, then CT-CAG is the best modality to assess the patient's coronary artery. Then for follow-up of CABG and angioplasty patient, assume that one patient had bypass surgery or a stent placement few years back, and then he developed chest pain, then the CT-CAG is the investigation of choice to assess the bypass graft patency and the patency of the stent. Then in post-transplant patient, if you want to look coronary artery, then this modality is best. Then asymptomatic high-risk patients. This is not indicated in any guidelines, included in any guidelines. But in day-to-day practice, CT-CAG is the best modality to assess the coronary artery in asymptomatic high-risk patients. So what all information we can get from CT-CAG? By CT-CAG, we can detect the coronary artery disease. We can assess the severity of the lesion. Then we can have coronary plaque imaging. This includes calcium scoring, non-calcified plaque or calcified, vulnerable plaque, then a stent patency, then graft patency. And for anatomical anomalies and for coronary artery, CT-CAG is far ahead than any other test. But we will not go into the detail of that. So one slide for what are the prerequisites for the patient who is going for CT-CAG. We need 3 to 4 hours fasting. Renal function should be normal. Heart rate should be in lower range, like 65 to 70. Still, in even with fastest machine, lower heart rate is needed to get clear images or to avoid the motion artifact. So we can do comfortably the lower heart rate with metoprolol 50 to 100 milligram according to the patient's heart rate if it is not contraindicated. There is no issue with that. Then a few seconds of breath holding, and in patient we cannulate with 18-gauge cannula to give IV contrast. So first we take the patient and do the plain scan without contrast for calcium scoring. This scan is ECG gated, and this is a very good and easy test for, you can say, screening. It is not included in any guidelines that it can be used as a screening tool, but many of the institutions in India using this calcium scoring scan as a screening tool if a subset of the patient and by calcium scoring we can detect the atheromatous disease in very early stage in young patient because at that age and initially the patient cannot have symptoms, and the ECG, echocardiography and TMT can be normal in those patients unless you don't have significant stenosis. So if you detect in earlier stage by this screening tool of calcium scoring, then cardiologist can give targeted therapy and advise to change lifestyle to the patient. And by calcium scoring, the more patient adherence and compliance will be better if patient knows that he has coronary artery disease. So it's a very easy test. It can be done in few minutes. There is no issue with heart rate if you want to do only calcium scoring. And it acts as a gatekeeper also. Like if we have very high calcium scoring, like more than 1000 Agatston score, then we don't go ahead with contrast CSG, contrast angiography, because that is the limitation for CT-CAG, because there is a blooming artifact due to heavy calcification. So we cannot see the lumen of the artery. So we usually stop at that time. Earlier, cutoff was 400. When you have Agatston score of 400, then you should not go ahead with contrast study. But nowadays, that is not the cutoff. We can go for CT contrast angiography, even at the score of 1000. We see nowadays that pattern of the calcification is important, not the load of the calcium scoring. So these are detail of calcium scoring, and you know calcium scoring. Calcium is the pathognomonic for coronary artery atherosclerosis, and risk of coronary vascular event increases linearly with high calcium score. So it's the most powerful predictor of subclinical atherosclerosis. So very important and very easy. Now I'm going to show you a few images of catheter and the catheter angiogram of the same patient to see the close correlation between the findings in CT and catheter angiogram. So this is a patient with a few asymmetrical calcified plaques in proximal LAD causing mild stenosis, and corresponding catheter angiogram, the finding is same. Similarly, this is the moderate stenosis caused by mixed calcified and non-calcified plaque in mid segment of RCA. You can see the same finding on the catheter. Similarly, non-calcified concentric plaque causing severe stenosis on catheter angiogram. So there is very close correlation between the CT-CAG and the finding on catheter angiogram. Now I'm going to show you my few cases so that you can have the visual understanding of images of CT-CAG. 37-year-old male patient, there was acute onset left-sided chest pain with sweating. And since then, patient is having occasional pin pricking sensation in the chest, and he was advised to get CT-CAG done. And he came to our center and we did CT-CAG. And you can see this is the LAD, very much clear. There is no disease, no plaque, no stenosis, nothing. This is volume render 3D images. Volume render images of the same patients, RCA, there's the PTA, there's the acute marginal, all are normal. So it's a totally normal CT-CAG young patient. Another patient, 42-year-old female with atypical chest pain. You can see this is a concentric non-calcified plaque in proximal RCA causing severe stenosis. You can see on the 3D images also. This is the very interesting case, 45-year-old male with chest pain. 2 to 4 days back, catheter angiogram was done in a reputed hospital in Patna, and there was significant disease in that patient. But patient was not mentally ready to accept his disease. And some of his relatives who are doctor who advised him to get CT-CAG done to recheck the finding. And he came to my center, and I convinced him, I tried convincing him that catheter angiogram is a gold standard, so there is no need to do CT-CAG in your case. But he insisted, and we did CT-CAG in his case, and you can see, unfortunately, I have not the image of catheter angiogram, but you can see there is non-calcified asymmetrical plaque in distal LM and proximal LAD involving ostium and causing almost complete occlusion of the LAD. So this type of incident can happen in day-to-day practice.
Sorry to interrupt, Dr. Ranjan, you have 2 minutes time left.
Okay, sure. So I'm just skipping. This is a vulnerable plaque. We can assess the vulnerable plaque on CT-CAG. No other test can do this. And that spotty calcification surrounded by fat attenuating soft plaque with positive remodeling. So you can see this is the calcification and the hypodense fat attenuating plaque. So this is the vulnerable plaque, which is very important for cardiologists. If we report in some patient, we can check the patency of stent if it is more than 3 mm by CT-CAG. You can see this is the 65-year-old male patient, patent stent in RCA, but blocked a stent in LAD of the same patient. Same patient had bypass surgery. This is Lima, which is patent, but you can see what are these two bulges in ascending aorta. So these are the blocked venous graft. We can see very clearly on CT-CAG. This is another patient, 71-year-old male, had a bypass in 2010 and now developed chest pain and did CT-CAG. You can see the Lima and the patent graft, and this was the image of previous patient. You can see these are the blocked graft. So for checking the bypass graft patency, CT-CAG is the investigation of choice. For anatomical anomaly, CT-CAG is again far better than other tests. You can see the anomalous origin of RCA with interarterial course and slit-like course in the intramural course, you can say in the wall of the aorta. So it's a malignant course of the RCA. So why still this catheter angiogram is gold standard? In terms of temporal resolution, still with even fastest CT machine, we have 75 millisecond of temporal resolution, but catheter angio has far ahead, far better than the CT, and it has 1 to 10 millisecond of temporal resolution. Another advantage of catheter angiogram is it has spatial resolution of 0.2 millimeter. However, CT has 0.6 millimeter. So these are the advantages with catheter angiogram, which enables this test as a gold standard. Only 2 slides left. What are the limitations of CT-CAG? If the patient's cardiac rate, heart rate was not static, it was variable, and the patient could not hold his breath during the scan, then the blood motion artifact is present, and we can see the lumen of the stenotic. Overestimation of stenosis in the case of heavily calcified plaque due to the blooming artifact of calcium. On CT-CAG, we can overestimate the stenotic segments. So these are the drawback already disadvantage of the CT-CAG.
Dr. Ranjan, sorry.
The last slide, CT-CAG is accurate, non-invasive, and number of lesion and plaque characterizations are the advantages with CT-CAG. And still, these two tests are not competitive. They should be complementary to each other. Finally, thank you very much, sir.
Thank you, Dr. Ranjan. Very nice presentation. Actually, coronary angiography, CT angiography is a very effective tool. So, Dr. Arvind sir.
Yes. Yes. Now we are just 3 minutes late. Now we move on to the next lecture. For that, may I invite Dr. Prem Kumar Head of the Department of Radio Diagnosis, AIMS Patna. Invite Dr. Mona Bhatia, Madam. Dr. Prem Kumar, are you here? Yes. Please unmute yourself, Dr.
Yeah,
Prem.
yeah. Good morning, good afternoon, everybody. And I'm here. And I invite Dr. Mona Bhatia, the renowned radiologist, who is familiar with all the things regarding the cardiac imaging. And without wasting time, I invite Madam to go with the deliberation.
All are requested to please keep muted. Only speakers unmute.
Thank you, Dr. Prem Kumar, and thank you, Dr. Arvind. It's a pleasure to be here. So we're going to be talking about the role of cardiac MR in the evaluation of coronary artery disease. After that excellent talk from Dr. Ranjan, where we've seen the impact of CT, so now we look at what MR does. We know that the number of patients waiting for non-invasive cardiac imaging is huge, and the echo train has stood the test of time. The echo has been the winner because it's easily available, portable, non-invasive, cost-effective with no risks. So what does cardiac MR really have to offer when we already have echo for so many decades? So what is the status of CMR in the world of echo? The classic cardiac axes in which we acquire the cardiac MR is in the vertical long axis of the two-chamber view, the horizontal long axis of the four-chamber view, and the short axis view. So the intention is to maintain the same angles and axes as is done for echo. The four-chamber view gives us a global view of the right atrium, right ventricle, left atrium, left ventricle, tricuspid, mitral valves. And then we have the short axis, which looks at function, wall thickness, and wall motion abnormalities. Further tagging can help to look at circumferential and torsional strain. The three-chamber view can look at the LV, the LVOT, the mitral, and the aortic valve. We have the RV inlet and outlet view. So we definitely get all the views of all the chambers. But the hallmark of CMR is really in myocardial tissue characterization, where edema and inflammation can be looked at on T2 weighted imaging. And this is particularly useful in the acute coronary syndromes such as acute MI and myocarditis. The first pass myocardial perfusion evaluates the contrast bolus as it's tracked from the RV cavity into the LV cavity and then through the myocardium with a very high spatial resolution. Not only that, this is done at 3 levels. So we're doing it at the basal, mid-ventricle, and the apical level, and we can have a very good quantification of myocardial blood flow when needed. The late gadolinium enhanced images are very useful because we can see the infarct, and these infarcts are seen as white lines, and here you can see a subendocardial infarct in the LAD territory. So CMR helps in the differential diagnosis of cardiomyopathies of ischemic versus non-ischemic based on the localization of the late GAD enhancement. The scars of ischemic are subendocardial, whereas those which are non-ischemic are usually more mid or subepicardial. Now, so CMR is definitely giving us this very comprehensive tool to look at cardiac morphology, volumetrics, wall evaluation, perfusion, area at risk, scar assessment, and various other additional findings. When we're talking about CMR and ischemic heart disease, the critical questions are function, perfusion, and viability, which form the basis of risk stratification, management, and prognostication. We know that CMR provides a gold standard for ventricular volumetrics with a very high spatial and temporal resolution. It gives a very accurate, reliable, and reproducible calculation of the end diastolic volume, end systolic volume, ejection fraction, cardiac output, and the myocardial mass. And if we compare CMR to echo in the evaluation of function for RV and LV, the coefficient of variation or the margin of error for echo is 11.5%, whereas that for CMR is 3.7%. And that is why CMR isn't the appropriateness criteria for quantification of LV function when discordant information occurs from prior tests. Why is perfusion important? Well, we know we're looking at hybrid imaging. The anatomical evaluation of the coronaries, we already know you have the options of CT angio versus the gold standard CAG. But at the functional level, we have many, many non-invasive modalities such as echo, SPECT, PET, MR with and without stress. And the impact of stenosis is extremely important for governing how the patient needs to be managed, whether it's ischemia, infarction. So ischemia-guided revascularization improves event-free survival over medical therapy. And that is why imaging of ischemia and viability is important. The perfusion defect can be very well evaluated on first pass imaging. Here you can see that while the rest of the myocardium has enhanced, there is a very definite perfusion defect along the LAD septum. The same thing subsequently you can see is a scar on late GAD enhanced images. Not only can we see the perfusion defect, we can actually have localization, quantification of these perfusion defects. And now we also have mapping methods where by perfusion maps, we can have segment by segment myocardial perfusion measures. Perfusion can be done both at stress and rest, and a defect that is seen at stress and not seen at rest indicates inducible ischemia, whereas one that is present at rest and at stress indicates that it's a scar. So here you can see that you have a scar which is both at rest and stress. In the detection of ischemia, CMR is superior to SPECT and perfusion echo. And in fact, it has a very good correlation with a very high diagnostic performance between CMR and PET. Third question is viability. And why is viability important? Because the likelihood of improved contractility post revascularization depends on viability. The basis of viability imaging is when you're looking at dysfunctional myocardium, the non-viable myocardium we know will not recover, but the viable implies that it has the capability to recover. And this is based on myocardial segments. If there's wall thinning less than 5.5 millimeters with wall motion abnormality, or if there is necrosis and scar, which is going towards transmurality and the contractile reserve, on the basis of these three features, we can look at viability on CMR. Here you can see how there is wall thickness and wall motion abnormality can be evaluated. Both regional and global wall thickness and wall motion abnormality can be assessed both at stress and rest. Here you can see the normal thickness. Here you know there is thinning of the basal inferolateral aspect, and you can see that even myocardial tagging further helps to improve the sensitivity. Wall thinning again can be well assessed. Here there is thinning along the mid-anteroseptal and here along the inferolateral basal segments. Wall thinning and wall motion abnormality seen where you can see in the region of the LAD when there was a scar, you can see this very specific thinning with regional dyskinesia. When we're looking at scar assessment, again, we can see how clearly we see the scar as a white line, and this can then be put into the 17 segment model to delineate and localize the scar. Not only can we localize the scar, we can even quantify the scar based on the total myocardial volume to the enhanced volume. So here there's a 19% myocardial involvement. And on comparison of the spatial resolution of CMR, SPECT, and PET, there is no doubt that the spatial resolution of MRI is superior. Here you can clearly see the scar, whereas in PET and SPECT, it's not to the same level. Novel mapping techniques also accurately identify imaging markers of the acute coronary syndrome, such as the area at risk, myocardial salvage, infarct size, microvascular obstruction, and intramyocardial hemorrhage. We know that the initial ischemia translates into a growing wavefront of necrosis, and while in less than 2 hours, you might have only a very thin line of scarring, as the time passes, this goes into a transmural impact. CMR helps to differentiate acute from chronic infarct, where on stir imaging within 7 days, you might see this area of myocardial edema, which is not seen after 6 months because the edema resolves while the scar may still be there. The area at risk is the area which is at risk being edematous compared to the scar, and the edematous area on T2 weighted imaging minus the infarct size gives us the myocardial salvage index. The infarct size again is very important, and late GAD enhancement is highly specific for irreversibly injured myocardium in the context of ischemic heart disease. A late GAD enhancement of less than 25% indicates that functional recovery is possible, and this area will recover contractile function. But if you have a late GAD enhancement of over 75%, it strongly suggests that the segment will not recover contractile function. There is no doubt that in acute late GAD enhanced images, you may overestimate the infarct size because the scar does shrink over time. The myocardial hemorrhage can be seen as a hypointense region within the infarct, and this has an association with a worse clinical outcome and has a higher cumulative event rate. Similarly, microvascular obstruction seen as an area of darkness within the infarct. Here you can see the transmural infarct on late GAD enhancement. This dark pore within it is an area of MPO, and this is a more accurate prognostic marker. So multiparametric CMR now is a clinical reality where we can identify pathophysiological processes such as the salvageable myocardium, the microvascular obstruction, core hemorrhage, and then LV thrombus and remote zones. Post-MI complications are also very well assessed on CMR. Here you can see a large aneurysm with an apical thrombus. This is a large thrombus sitting in the apex, and this white area is the scarred myocardium, which is thinned out and is seen ballooning outwards. This is a 48-year-old who presented with hypertension, type 2 diabetes, and had coronary artery disease and had a stent. There was a cystic solid mass seen in the basal interventricular septum. The question was it a pseudoaneurysm? Is it a drained abscess? But what we saw on the MR was rather classic. There was a LV pseudoaneurysm, and you can see how it fills in as the LV cavity fills in with the thrombus within it. In fact, when we went on to further assess this study, there was areas of scarring in the RCA territory. It was in fact an in-stent restenosis, and the patient had to undergo a CABG. Other complications such as LV apical thrombi are very well assessed on CMR. Here you can see that on echo, sometimes a soft fresh thrombus can be confused as a reverberation artifact, whereas the same can be very well assessed on the CMR, where you can see this perfusion defect. So in the detection of LV thrombus, CMR is superior to non-contrast and contrast echo, with the sensitivity of non-contrast echo being about 33%, contrast echo 61%, whereas cine CMR has one of 79%. Small thrombi may be missed on echo, but they are usually very well seen on the CMR. So how do we compare CMR to various other investigative modalities that we have? What is its role in the big fight? Well, the wish list for a winning modality is you want quantitative data, you want high spatial resolution, high accuracy, high reproducibility, and no radiation, and you want it to be safe. Well, does CMR provide quantitative data? Yes, definitely. We can see the perfusion defects, we can see the scars, we can put them into a 17-segment model, we can create quantification. So definitely we get an excellent image and we get very good quantification. Its spatial resolution is very high. And in fact, of as small as 1 ml of tissue can be seen on late GAD enhanced images. And here you can see that if you have a subendocardial infarct, which is about 1 to 25% transmurality, only 50% would be picked up on SPECT, but CMR would pick up many more. Similarly, CMR has a better spatial resolution than even PET. Going on to its accuracy, CMR has been compared to SPECT and histology, and CMR has excellent agreement with TTC histology, and so it is the preferred modality with higher spatial resolution. It has a very high reproducibility. These are images of MR 1 and 2 done on 3 patients who underwent CMR within 9 months interval time, and there is no intervening cardiac events. And you can see how there is very good reproducibility of the lesion. Further, CMR we know is non-invasive with no radiation at all, and so it is very safe. So going on to CMR versus other modalities, no doubt that CMR is the winning modality, but we're talking about function, infarct, thrombus, microvascular obstruction, hemorrhage, area at risk, or myocardial salvage evaluation with a radiation dose of 0. And so it is now become the third empire and is the basis of treatment planning and prognostication. On a comparative multimodality data on ruling out viability, that is, if you're looking at sensitivity and negative predictive value, CMR and PET are really close at 95 and 92, with CMR having the edge. Whereas if we're looking at confirming viability based on specificity and positive predictive value, low-dose dobutamine CMR is having an edge over dobutamine stress echo. So all in all, delayed enhanced CMR has the highest negative predictive value, and low-dose dobutamine CMR has the highest positive predictive value. So definitely it's an extremely powerful tool for evaluation of viability and risk assessment through area at risk, infarct size, ventricular volumetrics, MVO, hemorrhage, perfusion, and myocardial tissue morphology. There is no doubt that there are patients who present as the acute coronary syndrome, where we're looking at normal cath angios and troponin positive chest pain, particularly in the setting of COVID. And these are the non-ischemic cardiomyopathies and myocarditis. This is a 40-year-old who presented with dyspnea on exertion. We can see that there was LV dysfunction with global hypokinesia on the echo. The CMR demonstrated the similar global hypokinesia. But what is more important is that on T2 weighted imaging, we could see the myocardial edema with no perfusion defect. So that is what is important, that this is non-ischemic. And these patients sometimes, when the late GAD enhancement, may demonstrate the subepicardial mid-wall scars. The question in our country is always sarcoid versus TB. There were some lymph nodes, and we were able to biopsy and prove it to be sarcoid. So when you're talking about ischemic versus non-ischemic scar, very classically, the ischemic scars are subendocardial and follow the coronary artery territory. Those that are non-ischemic are subepicardial and do not follow the coronary artery territory. And the extent and transmurality of scar is extremely important for prognostic evaluation and to guide management. Another 42-year-old with dilated LV, global hypokinesia, normal CAG, and an ejection fraction of 20%. Very similar images between the BTFE of the CMR and the echo. The function, of course, CMR is the gold standard, but more than that, CMR demonstrates the myocardial edema as an area of whiteness seen along the T2 and STIR images. And you can see this fibrosis, which is mid-wall, which is associated with a much worse prognosis. TB is very common in our country. We see even youngsters. This was 13-year-old with a dilated cardiomyopathy with an ejection fraction of 20%. There was extensive myocardial edema, multiple lymph nodes, pleural pericardial effusions, and on late GAD enhancement, there were multiple small granulomas within the myocardium, and this was tuberculosis. Last but not the least, I want to touch base on Takotsubo, which is a reversible LV dysfunction without significant epicardial coronary disease. These have a very elusive pathophysiology and is precipitated by stress. Prevalence is almost 1 to 2% of the suspected ACS that arrive, although the condition is supposed to be relatively benign. And you have the contractile function, which could be typical form, which has the apical circumferential pattern, which is the hallmark, or the atypical Takotsubo, which is mid-ventricular variant, basal, and the dynamic pattern. Here you can see the typical apical ballooning of a Takotsubo patient. This has a mid-ventricular variant, where again, it is the mid-ventricular variant, which is showing the Takotsubo ballooning. And in suspected Takotsubo, the application of CMR is not only in getting myocardial function and looking at wall motion abnormality, but also in tissue characterization for edema and fibrosis. These patients very often demonstrate edema. And here you can see on T2 weighted imaging, the myocardial edema, and this is more transmural, and it may be diffuse or transmural, it may be apical or in the mid planes, and it's not restricted to a vascular territory, which is an important feature in these patients. On follow-up, this T2 hyperintensity reduces over weeks in the Takotsubo syndrome. Going on to the acute, the differential diagnosis of these patients is invariably acute MI, where we would be looking at coronary distribution with perfusion defects or scars. And in acute myocarditis, again, it will be more multifocal, heterogeneous with subepicardial scars. Here on the first pass perfusion, you can see in Takotsubo, they're usually normal in the vast majority with no evident defect in the myocardium. But sometimes you may see patchy late GAD enhanced images reflecting diffuse reactive fibrosis. But usually other findings that may be seen in the Takotsubo lot is pericardial effusion, pleural effusions, and ventricular thrombi. Here you can see the pericardial effusion, which is seen around the pericardium. You can see here pericardial and pleural effusions, and not infrequently you might see thrombi in these patients. The RV involvement in Takotsubo is known to occur, and you may have biventricular ballooning, which indicates a more severe prognosis. The follow-up usually requires 3 to 6 months after presentations, and they usually recover well. So definitely going all in all, cardiac MRI is an extremely robust, non-invasive diagnostic tool. It has a very high sensitivity, a high spatial resolution, a high accuracy, a high reproducibility, low operator dependence, with no radiation, a wide scope in cardiac evaluations. It acts as a very, very complementary role to echo and nuclear medicine, both to confirm the diagnosis, establish the etiology, assess the severity, guide management, prognosticate, and follow up patients. So for cardiac imaging, we are truly spoiled for choice. The cardiologists have ECG, echo, SPECT, PET, CT, and MRI. And no doubt, lots of times it's MRI, which is the final word and the third umpire. Thank you so much for your patient listening.
Yeah. Thank you, madam, for your fantastic lecture on MRI. In such a short time, you have almost covered everything. And it appears that this is the best modality. Unfortunately, in Bihar, the facility is not available. So the question and comments will be at the end of the talk. Once again,
Sure.
Thank you, madam.
Thank you. Thank you so much.
Now,
Thank you, madam. Thank you.
Now, I have the pleasure to invite Professor V.S. Narayan from Lucknow. He is the retired professor and head of the department, King George Medical University. Presently, he is the attached with the Divine Heart Hospital as an head of the department cardiology. And he will be speaking on a very demanding subject, role of chest X-ray in heart disease. Very important session. Everyone would love and like to hear his lecture. He's a great teacher of the teacher. Please, Professor V.S. Narayan, sir, please go ahead. Sir, you are muted. Please unmute, sir.
Can you hear me?
We cannot hear you clearly, sir. We can see your face. Can some technical person should help Professor V.S. Narayan?
Yeah, I don't know, but
Can you hear us? There's some technical problem. Can somebody help?
Sir, can you share again once more?
I can hear very well somehow. Okay, now, say you are muted, but I am unmute over here. So what you can do is you can carry on with the next lecture and I'll join in again. In order to save time, you can have the next lecture and then I will join again. Try to do that because on my end I am not.
Okay, sir.
The next speaker, Dr. Rakesh Gupta from Delhi, has joined.
No, sir has not joined yet.
Then
Maybe Doctor, if the bandwidth is low from Dr. V.S. Narayan sir, maybe he can just put off his video and just try once.
We are
Sir, could you please?
We are asking him to send the PPT to us once.
Yes, and he can just put off his video so that the bandwidth is low, then we can.
Sir, you can. Yes, just video.
सुनाई दे रहा है?
जी सर, आवाज आ रही है.
बहुत हल्की आवाज आ रही है.
अच्छा.
Come closer to your mic.
Okay, I am close enough actually. Now can you hear me?
Yes.
It is better, much better.
Much better.
So let me thank you for asking me to give a lecture on X-ray. Just after hearing about the MRIs and the CMRs and the CTs, X-ray lecture looks like a poor country cousin. It's like KL Sehgal trying to sing with A.R. Rahman. But I think this lecture is important, especially for the postgraduate students, and I'll try to cover as much as I can because obviously the material is quite a bit. But whenever your timer is up, you ask me to stop and I will do that. Am I audible?
Yes, yes. Yes, sir, go ahead.
I can't see the timer over here, so I don't know.
We will give you reminders, sir, 2 minutes before.
Okay. So the first thing that you need to do is basically see whether it is an AP view or the PA view, because if it is an AP view as evidenced by the shadow of the scapula on your lung field, you will have some kind of false cardiomegaly. So the importance of AP would be that if you have no cardiomegaly on the AP view, you can be sure that the patient does not have any cardiac enlargement. So
sir, we can't see your slides. We can't see your slides.
You have to share your presentation.
अब दिख रहा है?
Yes,
now
sir.
it is clear.
Quite
Yes.
visible.
Okay, sorry about
Good
that.
afternoon, sir.
Yeah, so I was saying that you need to be sure that this is not a AP view, but it is a PA view because AP will give you a false sense of cardiac enlargement. But if you do not show cardiac enlargement, even on the AP view, you can be sure that there is no cardiomegaly. Then you have to look for rotation. If the patient is rotated to one side, you will have not have an equidistance from the central line of the clavicular medial ends, and then one side of the lung will be hyperinflated, will be black, and the blackness would be on the side your homothorax is rotated. So on this X-ray, it is onto the left side that you are rotated. Rotation can also give you a false sense of cardiomegaly. If the patient is rotated to the left, the heart may appear enlarged. Then you need to have an inspiratory film to have a clear picture of the heart and the lung fields, and you need to count the anterior ribs and the posterior ribs. So anterior ribs, it should be at 6, the diaphragm should be at 6, and the posterior ribs, as you have counted here, it should be at least at 9, but good to have it between 10 and 11. So the importance of the inspiratory film is that if it is not an inspiratory film, you will have a false sense of cardiomegaly, and then you can have some kind of infiltration coming up in the bases. But if you have a good inspiratory film, the same patient will look like this. Cardiomegaly, we know that the ratio in an adult is about 50%. In the newborn, it is 60%, and in the infant, it is about 55%. But if it is more than 70%, it is gross cardiomegaly. And if your borders of the heart is touching the ends of the thorax, it is a massive, massive cardiomegaly. Now, this is something which is asked in the examination. If you look at the X-ray, you see the protuberances. Let us trace the X-ray, the severe vena cava, the right atrium, the right ventricle, the left ventricle, the left atrial appendage, the main pulmonary artery, and the aorta. And the aorta, the main pulmonary artery, and the left atrial appendage are often called the three moguls. This is a massive left atrial enlargement and an LV type of apex, which you see in patients with mitral regurgitation. This is left atrial enlargement and a right ventricular type of apex, and no significant cardiomegaly, which you see in patients with mitral stenosis. If you look at the barium meal, which you don't see very many nowadays, if you have a small arc of a big circle, this is more or less like that of a mitral regurgitation because of a massive LA enlargement. And if you have a big arc of a smaller circle, this is a smaller left atrium, which you see often in cases of mitral stenosis. Another parameters which you look for LA enlargement, you all know that the left bronchus can get lifted, the left atrium can give you a double shadow. So if you draw a line from the mid of the lower part of the left bronchus onto the inferior lateral part of the left atrium, and this measures more than 7 centimeters, this is the oblique diameter, and you can be sure that the patient has left atrial enlargement if other features are not put up. Another sign often asked for left atrial enlargement is the walking man sign, and this is when you have a left main bronchus lifted up, the right main bronchus straight down because of left atrial enlargement, and you have some impression as if a man is walking, and this is the walking man signs for left atrial enlargement. The question often asked in the examination is how you differentiate between RA and LA. The RA will cut the diaphragm, the left atrium will not cut the diaphragm, and this is how you can differentiate between the two. An aneurysmal left atrium, when it enlarges and approaches within an inch of the lateral wall, this is an aneurysmal left atrium, often called the left atrial escape in patients of mitral valve disease. Criteria for cardiomegaly, sometimes in old age, you cannot measure the CT ratio, and therefore you have to go to the absolute values of 15.5 centimeters in male and 12.5 millimeters in females. A criteria often asked in the examination for left ventricular enlargement is the Hoffman-Rigler sign. It is the distance between LV and the posterior border of the IVC. The IVC, you take a measurement from diaphragm, where the diaphragm cuts the IVC 2 centimeters up, and from there you measure the distance to the left ventricle, and if that distance is more than 1.7 centimeters, it is a positive Hoffman-Rigler sign indicative of a left ventricular enlargement. And coming to the mal positions, this is normal situs solitus because the left ventricle is onto the left, the apex is onto the left, and you have a gas bubble, that is the stomach bubble onto the left and the liver shadow on the right. So this is abdominal situs soleus. The cardiac apex is to the left, and the bronchus we will see here. So you know that the left bronchus is long and curved, the right bronchus is straight and short, and this ratio is a ratio of more than 2 in a normal situation situs. If the ratio is less than 1.5, then it is either a right-sided bronchus on both sides or a left-sided bronchus on both sides, called the isomerism. The eparterial and the hyparterial, the right bronchus is above the pulmonary artery and called the eparterial, and the left bronchus is below the pulmonary artery and called the hyparterial. And some of these, things are often asked in the examination. That is why I have included it. Now, if the apex is on the right, it is dextrocardia. But if it is in consonation with the gas bubble, it is mirror image dextrocardia, and you normally have no cardiac defects in such patients. You just have isolated dextrocardia. But if the apex and the gas bubble are dissociated, for example, in this situation, the apex is on the left side, the gas bubble is on the right side. This is dissociation. This is isolated levocardia. Levoversion, it is mostly accompanied by complex congenital heart disease. Similarly, a right-sided apex, dextrocardia, and dissociated with the gas bubble. So this is isolated dextrocardia, dextroversion, once again associated with complex congenital heart disease. If the heart is sitting in the center, it is mesocardia. And if the liver is sitting in the middle, no gas bubble, this is once again situs ambiguous and associated with complex congenital heart disease. How do you decide the side of the aortic arch? You have to look at the indentation on the trachea. If it is onto the right side, it is a right-sided aortic arch, and then you see shifting of the trachea. If the trachea shifted to the left side, that means the right-sided aortic arch is pushing the trachea to the other side. And this is the two methodologies of deciding the arch is left or right. In this case, the arch is on to the right side because you see this indentation on the trachea. Now, coming to congenital heart disease, one should start interpretation with looking at the pulmonary artery. If you find that the main pulmonary artery segment is absent, you are looking at a tetralogy, physiology-like situation. If you see that the main pulmonary artery segment is prominent, you could be dealing with either pulmonic stenosis or a pulmonary arterial hypertension. And in order to differentiate between the two, look at the right pulmonary artery. If it is prominent, it is pulmonary arterial hypertension. If it is absent, it is pulmonic stenosis. How do you know that the pulmonary artery segment is prominent? You draw a line from the base to the apex, and if your segment either touches this line or goes beyond it, it is prominent pulmonary artery. How do you decide that the right pulmonary artery is prominent? You measure it in the mid segment. It should be more than 17 millimeters. And if you cannot take a measurement, compare it with the trachea. It's more than tracheal diameter. It is a prominent right pulmonary artery. As I said, look at the right pulmonary artery. If it is absent with the main pulmonary artery segment being prominent, you're dealing with PS. If the right pulmonary artery is also prominent in association with main pulmonary artery, you're dealing with pulmonary arterial hypertension. And these are the angios which show that. Prominent pulmonary artery, but diminutive right pulmonary artery, prominent right pulmonary artery, and huge right pulmonary artery. Pulmonary blood flow could be increased, decreased, or normal. Divide the lung fields into three parts. If you can see vasculature till the middle part, it is normal flow. If it is localized to the medial part, it's a reduced flow. And if you can see it all through, right from the medial to the lateral third, it is increased pulmonary blood flow. Now, when you see increased pulmonary blood flow, it is important that you see both the upper and lower vessels. They have to be equally prominent, because if they're unequal, you could be dealing with a pulmonary venous hypertension situation rather than flow, and we will discuss that subsequently. Here you see the vasculature in all three fields, so it is increased pulmonary blood flow, and the main pulmonary artery is prominent. You can see end-on vessels. Here, they are very classical for increased pulmonary blood flow. Once again, another example of end-on vessels being seen. And then you compare the diameter of the bronchus with the end-on vessels. And the end-on vessel should be more than the diameter of the accompanying bronchus to be called a prominent pulmonary blood flow situation. In the examination and otherwise, you're often given this kind of X-ray and you think it is pulmonary blood flow. But as I said, try to look at the lower as well as the upper fields. If the lower fields are clear and the upper fields are full, you're probably dealing with a pulmonary venous hypertension situation. Other things that you need to look at besides this upper lobe veins inequality, these are the other signs of pulmonary venous hypertension and end-on vessels, which we've already seen. What are the other signs of pulmonary venous hypertension? you have inequality, upper lobe veins prominent, lower veins absent. This is pulmonary venous hypertension. What are the other signs of venous hypertension? Curly V lines. You can have curly C lines. You can have curly A lines, but curly V lines are the ones which are horizontal and at the base. This is pulmonary edema, something which is spreading out from the hilum, giving a bat wing appearance. This is not increased pulmonary blood flow. This is bat wing pulmonary edema. This is something which you don't see anymore. This is hemosidrosis, because we do pulmonary artery mitral valve valvotomy so early that you don't get to see hemosidrosis, and you don't get to see these hemosidrosis going into ossification nodules, which you used to see in our times. And this is what you see on the CT, ossification within the lungs. Now, what is this? Is this pulmonary edema? This is very classical for something which we call the S1Q3 T3 syndrome. This is pulmonary embolism, very classical wedge-shaped shadows. This is neither increased pulmonary blood flow, nor is it pulmonary venous hypertension. Now, coming to reduced pulmonary blood flow, you divided the lung fields into three, and you find the vasculature only in the medial lung field. So this is reduced pulmonary blood flow. Now, when you have reduced pulmonary blood flow, you could be dealing with an infundibular stenosis, where you can have an absent MPA, or you could be dealing with a valvular PS, where you have a main pulmonary artery prominence. Here, there will be no cardiomegaly, but here there will be significant cardiomegaly because of tricuspid regurgitation. This could be with or without a reversal anti-atrial septum. So this could be triology physiology or simple severe pulmonary stenosis, and this is tetralogy physiology. This is decreased pulmonary blood flow of tetralogy physiology. This is increased pulmonary blood flow of another situations. So MPA prominence, you know, can be because of increased pulmonary blood flow, could be reduced pulmonary blood flow with valvular or pulmonary arterial hypertension. This we have often seen. This is increased pulmonary blood flow. But this is what we call pulmonary arterial hypertension, the classic jug angle picture of Eisenmenger syndrome. Here you see prominent right pulmonary artery, but there is a pruning. There is no significant vasculature here in the periphery as compared to this. So this is increased flow, but here this is development of pulmonary arterial hypertension with the decreased flow, no flow here in the periphery. And this is what we call the pruning. Pulmonary pruning, another example. Main pulmonary artery is prominent, but periphery is clear. So sudden tapering off is pruning. The right pulmonary artery we've already discussed. It has to be more than 17 millimeters in diameter in the mid part. How do you differentiate Eisenmenger from tetralogy? There will be no significant cardiomegaly in Eisenmenger, while except perhaps for ASD Eisenmenger, while there will be gross cardiomegaly in patients with triology physiology. Another example of cardiomegaly with cyanosis is sitting on the right side. This we know was triology. How do you differentiate triology from what we call the Epstein's anomaly? Look here, there is no main pulmonary artery segment. Here the main pulmonary artery segment is prominent. So blood flow is reduced, but this is physiological reduction of blood flow because of Epstein's anomaly, and this is true pulmonary stenosis. So this is Epstein's, this is triology physiology. Left to right shunts, a quick revision. If you see the aorta is enlarged, you're probably dealing with RSOB, aortopulmonary window. If you see the arch also prominent, you're dealing with PDA. But if you don't see the aorta, then this is a pre-tricuspid shunt, ASD, TABVC, or VSD. ASD will show right atrial enlargement, main prominence of the main pulmonary artery, and a right ventricular type of apex. A VSD, on the other hand, will not show so much of right. It will show enlargement of the left atrium, and the apex here would be of the left ventricular type. In a PDA, you will get a left atrium, a left ventricle, but in addition, you will get the aorta prominence. So what do you see? If you have to differentiate all three left to right shunts, right atrial, right ventricle in ASD, left atrium, left ventricle in VSD, left atrium, left ventricle and aorta in patients with PDA. If you look at the superior vena cava and it looks very prominent to you, you could probably be dealing with a pulmonary with a partial anomalous pulmonary venous connection. And in this connection, you can have this very classical, curiosity, which is often brought in the examination, the Schmidt-Arch syndrome, which is drainage of one of the pulmonary veins on the right side or the entire pulmonary veins down into the inferior vena cava and gives rise to this typical shadow, which we call the Schmidt-Arch syndrome. Is this another Schmidt-Arch syndrome? The answer is no. This is pulmonary artery venous fistula, a clear-cut abnormality here. This is not scimitar, this is pulmonary AV fistula. Now, coming to reduced pulmonary blood flow. In reduced pulmonary blood flow, there are some common features. There is no cardiomegaly. The main pulmonary artery segment is absent, and there is reduced pulmonary blood flow. Very classical picture of tetralogy. And in tetralogy, you can sometimes get this type of crisscross features, which are those of collateral circulation. Now, if you have somebody presenting like tetralogy physiology and you look at the X-ray, and instead of this classic right ventricle, you get a left ventricle, then you are dealing with tricuspid atresia. So the difference between tricuspid atresia and tetralogy is tetralogy you have a RV, in tricuspid you have an LV. And you even have a very classical absence and straightening of this border on tricuspid atresia. And this is because the RV is becoming diminutive and the atrial appendage is juxtaposed to the opposite side. So this straightening left ventricular apex in a tetralogy-like situation tells you about tricuspid atresia. Sometimes you are given this X-ray and you confuse this X-ray with that of tetralogy. It looks very much like tetralogy, but try to look at the periphery also in these cases and ask whether this patient is cyanosed or not. So this patient was not cyanosed, but if looked at the periphery, you find indentations on the inferior border of the posterior ribs. And you look at the aortic region and you find this classical indentations or cutout portions on the inferior portions, and you have this figure of 3 sign. The figure of 3 sign is formed by the dilated subclavian artery, the constriction of the aorta, and the post-stenotic dilatation of the aorta. And you can have an E sign on the barium meal and a 3 sign X-ray. Can this be tetralogy? The answer is yes. Normally, we're expecting no pulmonary artery here, no pulmonary artery here. And look what we have over here. So the very classic picture of a Mickey Mouse sign with top with absent pulmonary valve. Another tetralogy with absent pulmonary valve looks similar to what we just saw, but look at the blood flow here. The blood flow is increased. And this is a classic situation of a continuous murmur with cyanosis, a figure of 8 or a snowman sign, which is total anomalous pulmonary venous connection. The upper part of the 8 is formed by the vertical vein draining into the dilated supravena cava in the right atrium, and the lower part is formed by the ventricle. So this is classical figure of 8, total anomalous pulmonary venous connection, often also called the cottage lobe and snowman in a hailstorm. Snowman sitting here, and the hailstorm is the increased pulmonary blood flow which you see in the lungs. In total anomalous pulmonary venous connection, you can get a constriction between the pulmonary artery and the bronchus, or when this common vein is going down to drain into the hepatic veins, this can get constricted at the site of entry below the diaphragm.
You have 1 minute left.
Okay, 1 minute. I'll just finish. Whenever you ask me to stop, I'll stop. So an obstructed TFVC gives this kind of picture, a hazy picture, a hyaline membrane type of picture, and the differential diagnosis, of course, is also hyaline membrane. The differential diagnosis is also hypoplastic left heart syndrome. The hypoplastic left heart syndrome can be differentiated with the presence of right atrium and absence of the left ventricle, but sometimes it becomes very difficult to diagnose between the 3. But this is the last couple of slides. Cyanosis at birth, you have an egg on side and a narrow pedicle. This is detransposition of great arteries, and you have an absence of the thymus, and the anterior posterior position of the vessels give rise to a narrow pedicle. So a narrow pedicle and egg on side, very classical. Thymus gives 2 types of signs, the sail sign and the wave sign. This is the thymus, which becomes absent when you have cyanotic heart disease, and on treatment it comes back. So I think this was, as much as I could tell you how you differentiate between the 2 X-rays of transposition with tetralogy. In tetralogy, you do not have any significant cardiomegaly. The lung fields are clear. In this, you have an egg on side, but the lung fields show increased pulmonary blood flow. So egg on side, increased pulmonary blood flow transposition, decreased pulmonary blood flow tetralogy. So I think I need to stop here because I know X-ray is such an extensive and vast topic, and I try to cover as much as possible. But maybe later I can take it over with some of the postgraduates when they're sitting around. So thank you very much once again for giving me this opportunity.
Thank you, sir,
And,
for your
discussing this
brilliant, excellent, masterly talk on X-ray. We have become more wiser today. We were forgetting X-ray interpretation in the era of echocardiography. So once again, we really congratulate you, and we really grateful to you. And we will in future we will have more and more lectures from you whenever we organize such a conference. Now,
thank you.
Thank you, sir. We move on to the next talk. I would request Dr. Manish Kumar, a senior echocardiographer from Bhagalpur, to invite Dr. Rakesh Gupta from Delhi. Dr. Rakesh Gupta doesn't require any introduction. Dr. Manish, please.
Yeah, good evening. Good afternoon. Thank you so much, Dr. Arvind sir and organizers. It is really my pleasure to welcome and invite Dr. Rakesh Gupta. He is our not just my guru and mentor, but a teacher of all teachers, and he needs no introduction. He is the director and the chief cardiologist at Europe Institute of Echo, and he has held a number of positions in CSI, API, so many bodies. And if I continue for his CV, then it will take another 15.
Request Professor Dr. Rakesh Gupta to continue or to start his lecture. Dr. Gupta, please.
Good afternoon, everybody. Welcome to this CARDICON 2021. I'm Dr. Rakesh Gupta, going to talk about something different, something unique, what's happening in echocardiography. Dr. Debika was very categorical in saying these. The excellent presentation of multiple cases, which I'm going to show a couple of more in this particular slides. Look, that's a history, almost 1990 when this Doppler technology was evolved. And in 2014, more than 4 lakhs papers were published. And now there are almost 1 billion papers are published on this Doppler technology. Is this the stain which we look for every day? And when we talk of a stain, people get stained like this and they look like this. Well, how this evolved? Look, this is a one thing which we have been doing for a long, long time. We are looking at a color flow, blood flow velocities. Some intelligent gentleman, he said, let's get rid of the blood flow. Let's look at the myocardial contraction. And he divided the myocardial contraction for systolic as red color and a diastolic as blue color and systolic. And it gave you a waveform also, in the sense like if you have a systolic contraction, positive deflection is seen, and if the relaxation is negative, deflection is seen. But the issue was when we devised this particular technology, we never realized that heart is consisting of 3 different kinds of fibers, longitudinal, radial, and circumferential. And we were only looking for one kind of a fiber that's in longitudinal directions. And this longitudinal direction of fibers, they do not contact in the same direction as the contraction of the heart is. Some fiber contact like this and the fiber contract like this. So one dimension classic echo, talking of a 2D strain, was not really adopted over a period of time. What exactly happened then? We went on to do a 2-dimensional strain. In the sense, we started looking at a sonomicrometer of a distance, how much this distance is moving from one location to other location. And this was done in 2 dimensions. And what was the net result of doing in 2 dimensions was, we were able to see the contraction of the heart in this particular fashion. This particular fashion of a contraction of a heart, we were able to see the systolic contraction in a negative form. I'm not going to detail why negative or negative deflection is present, but we were able to see the contractual segment like -24, -18, -15 in 4-chamber view when we talk of septum as well as lateral wall. Similarly, we were able to do in 3-chamber view, and similarly in 2-chamber view, and comes to a completely a bullseye kind of a pattern. And this bullseye kind of a pattern gives you a lot of information on 2-dimension strain. This bullseye gives you a differential strain looking at individual segment as well as average global longitudinal strain, which is seen over here is -19.3. Well, normally, as on today, if I talk about, we don't look at a differential strain, we look at a GLS, or an average GLS, and which is anything more than 18. Some people say it's 17.5, some people say that's 20. Let's take a congregation of almost 18 to 20% of a minor strain is considered as normal. So in turn, it gives you what? It tells you how much my LV is contracting, that's contraction and synergy. then whether these segments are contracting at the same time or at a different time, that's talk of a synchrony. So one particular modality available as on today can give you both synergy as well as synchrony of the LV contraction. But the issue was we only looked at the longitudinal strain. We went at further to look at a torsion and twist, which was able to understand radial and circumferential strains. And this radial and circumferential strain gave you a basal function in the form of a net twist. And this net twist is seen in this particular slide over here. Like we could see this net twist, whether these segments are contracting normally or these segments are contracting abnormally. And that is what is available as on today in the market to look at both longitudinal, transverse and radial strains in this particular phenomena. We not only looked at LV, we also looked at an RV in a similar fashion. Let's see what are the implications. Tons of implications are available as on today. What are these tons of implications? You can look at anything. And today I can talk about like what does the LV function evaluation? It's not only the EF which is important, but it's a two-dimensional strain which is important. And this was published in JACC 2019. A relationship with EF and strain permits a more accurate observation of LV systolic function. The value is almost 3 times of a strain gives you a rejection fraction, and which is seen in this my recording. I'm going to show a recording in 2 minutes time. We recently recorded this in automated fashion. This is a 3-chamber view which we are going to record. And once we do a 3-chamber view, we are going to show a 2-dimensional strain, and the machine automatically identifies this 2-dimensional strain. Once it identifies 2-dimensional strain, it gives you a 2-dimensional strain value also. And here is a 2-dimensional strain value of minus 21.8. And it shows synchronicity of all 6 segments of the contraction of LV, including the ejection fraction, which is shown by next slide. I'm going to show the next slide in a couple of seconds. As soon as you show the machine, the 4-chamber view, machine automatically does a 2-dimensional strain. And it not only does a 2-dimensional strain, it also gives you one more phenomena. That is what the GLS as well as ejection fraction, which is going to come in a couple of seconds. And here comes the 57% of ejection fraction.
For example,
in these 2-chamber view, we can really avoid that.
One look at it, I think it is really mind.
We can look at this 2-chamber view, and those 2-chamber view also gives an absolute value of our 2-dimensional strain. And with this 2-dimensional strain, we can really observe the ejection fraction. We are trying to align this particular picture over here. And this gives you a real value of both 2-dimensional strain as well as the GLS. Here the GLS is 23. Synchronicity of all segments in 4-chamber, 2-chamber, and now you look at the ejection fraction, which average ejection fraction by plane method is 60% and 61 by 2-chamber. So this is what is that, suggesting that GLS is more important than ejection fraction in this particular scenario. Let's look at this patient, which was done only 2 days down the line. 33-year-old male presented with heaviness chest since 12 hours. Diabetic, he is. ECG normal, tropi normal. And if you look at this echo over here, this echo was absolutely normal. And we did a 2-dimensional strain, even 2-dimensional strain was reasonably normal for this patient. Patient went back, nothing abnormal was there. Still, we advised him an angiogram. He said, no, I'm going to go home with a condition that he'll come back again. We'll have a repeat enzymes and ECG. Next day, he was much better than like yesterday. We did a tropi. It came out to be positive. And only one finding was inverted T wave in AVL. And look at an echo now. Echo is again normal. There's nothing wrong with echocardiography. LV contraction was reasonably normal even today also. But once we did a 2-dimensional strain of the same patient, it shows an LCH territory, which is differentially changed as compared to yesterday with the tropi positive. And now this patient was ready for an angiogram, and we did do angiogram in this patient, which showed an LCH territory. Then prognostication of ischemic cardiomyopathy. Well, all of us, we understand ischemic cardiomyopathy very well. We do a lot of ischemic cardiomyopathy. Will we ever think like what is the prognostication of this ischemic cardiomyopathy? Here's the GLS of this patient of a dilated cardiomyopathy, and this GLS is almost 6.2. And if this GLS is 6.2, and if you look at this graph which was published in JACC 2010, if the GLS is less than 7 versus more than 7. So if it's more than 7 means a negative side. So 8, 9, 10, 11, they do worse as compared to the GLS, which is less than 7. Then RV function evaluation. I'm showing you slides of how do we used to do an RV function evaluation earlier. We were doing in a conventional method by looking at RV free wall TDI, and we are measuring a TAPSE over here in RV. Then we'll go ahead and measure what? We'll measure what? The tissue Doppler by RV free wall TDI. But this automated strain with artificial intelligence can really help us in giving you an exact information of RV function, as well as the RV ejection fraction and the 2-dimensional strain in these people. It'll show in a couple of seconds. Now it's measuring. It measured RV TAPSE. Now it's measuring the 2-dimension RV strain over here. And look how much time we devote. With this automated function and artificial intelligence, we can really change the scenario completely in these subset of population. Now I'm measuring over here as I'm doing an echo lab. But if I'm using my artificial intelligence, I'm using a 2-dimensional strain and doing an automated evaluation, I do it in less than 30 seconds time. That's what I wanted to show over here. Here comes the automated function. We bring the image completely back. Here comes the image. We just put a few dots on this image, particular image. And machine does the rest of the work automatically. So first dot, RV free wall. Second dot is interventricular septum. Third dot is RV apex. And the machine analyzes all these things together in one go. And now we can adjust these sonomicrometer distances or the area of interest for evaluation. And now once we go for processing, it gives you tens of a value. And what that value will have, now it gives you a GLS of -19, free wall systolic contraction by TDI 19.3 and a TAPSE 2.2. And on top of that, the most important part is look at the synchronous contraction of almost all segments. And that's what makes a difference for this prognostic value. What is the difference? A person who has got a normal one, this is what the contraction is. If it's acute pulmonary embolism, we all remember the mechanism size, apical sparing is present, mid and basal segments, they contract less. And in chronic pulmonary artery hypertension, all the segments, they contract less. And this is not possible by any other mean when the patient walks into a casualty with sudden onset breathlessness. And when we want to differentiate whether this is normal or acute pulmonary embolism versus chronic pulmonary artery hypertension. Heart failure. Prognostic value of tricuspid annulus tissue Doppler velocity in heart failure and atrial fibrillation. Look at the tricuspid annulus velocity, both S wave as well as septal S wave. And when we plot this E2 in prime septal velocity, tricuspid septal velocity more than 9 versus less, septal E prime less than 7.3 versus more than 7.3, they have a certain differential values of cumulative mortality and survival. Now their ejection fraction is more than 55 on a top, less than 55 on a bottom graph. What really makes a difference when we are doing these kind of a job in echo lab? Next comes, every one of us is very afraid of aortic stenosis. Whereas, what do we look at aortic stenosis? We look at aortic area, normal ejection fraction, low gradient, low flow. And that is the most important paradoxical aortic stenosis. We see approximately 30% of patients of aortic stenosis having a poor prognosis. We subject them to myocardial dysfunction analysis by GLS. And once we do a GLS analysis in this subset of population, we'll same gradient of high gradient and we plot it. And to see that if the GLS is low, here is the example of a patient who was a low flow, low gradient paradoxical aortic stenosis with a low GLS. And we subjected that patient for surgery and look at his GLS after surgery improving from 7.6 to 14 and subsequently going after 6 months to 14.6, almost a complete recovery, if not a near recovery, a complete recovery. Then hypertrophic cardiomyopathy. Have you ever spent time on hypertrophic cardiomyopathy to look at a prognostic value? Never ever. We always look, maybe sometime we look at a BNP, but if you have an E2 prime ratio low versus high E2 prime ratio, higher the E2 prime ratio is, less or poor prognostic factor as compared to low E2 prime ratio. Now it has been compared with BNP level as well. Chemotherapy. I'm sure many of us are in this particular field of chemotherapy. Here is a 58-year-old female with a CA breast and a chemotherapy and echo. And once we do an echo in this patient, LV function is absolutely normal. What do we do? Can we take up the chemotherapy? And that's what we look at the GLS 17.4 in this patient of CA breast on chemotherapy. What do we do next? There's a definite guidelines talking about all these kind of things. This says that if there is a drop of more than 15% of the previous GLS, it means if my previous GLS was 20, if it becomes less than 17, that is 15% drop, more than that, or it becomes 16.5, we have to postpone the chemotherapy for a couple of weeks till this LV function improves considerably. And that cannot be identified by pure ejection fraction. My quest of telling everybody out here is, look, we are talking of EF, 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 EF. Believe my words, EF contributes to only minuscule 2 to 5% in our echo practice as on today. Restriction versus restriction. Many of us will always deal, and our surgeons, they keep on shouting in the OT, hey, you have sent me not a constriction, it's a restriction. Can we diagnose this constriction versus restriction? Here is an example. We can two-dimension stain. By looking at a two-dimension stain, we can differentiate constriction versus restriction. Apical longitudinal stain is reduced in construction, and here I've put up these markers over here. Apical septum, apical lateral wall. This apical lateral wall is pink in color and apical septum is green in color. Look, this is small or reduced two-dimension stain versus restricted cardiomyopathy, dilated LV, thou, but the green segment shows almost a normal two-dimension stain. That is one. How can we differentiate it? Second, look at a tissue Doppler at mitral annulus. Mitral annulus E prime velocity is always less than septal E prime velocity in a normal tissue Doppler. But what happens when we have a constrictive pericarditis? This E prime of the septum becomes considerably lesser than E prime of lateral annulus. Only fact is if it's normal. But if this lateral annulus becomes less as compared to septal annulus, this is what the constrictive pericarditis is. Systemic illness, chronic kidney diseases, lot of role for atrial stain. Then comes diabetes mellitus. Have you ever thought of a diabetes mellitus of the patient? Everyone is dealing with diabetes. At least I see at least 1 out of 3 people in my clinic having a diabetes mellitus. Did we ever thought of a diabetes mellitus with two-dimension stain? Here is a data from a diabetes mellitus. We look at ejection fraction. Look at a subclinical LV dysfunction in the diabetes mellitus. This is diabetic, this is non-diabetic, this is diabetic, this is non-diabetic. But we look at a E prime longitudinal stain versus in diabetic population, we can find out these people are getting into subclinical LV dysfunctions. And what the diabetes they suffer with, either they suffer with microvascular disease or they suffer with microvascular disease. It is better to suffer with a microvascular disease that is correctable. And it's very difficult to treat a microvascular disease when the patient presents with a dilated LV. And this we can pick up right in the beginning when we start looking at these kind of things in a patient who is a diabetic without any overt heart disease and displays subclinical LV dysfunctions. Pregnancy is postpartum. None of you have ever thought of this particular phenomena in pregnancy and postpartum. The answer is, if you look at a pregnancy, look at that GLS, which is very easy to look at it. If the GLS at presentation with a cutoff value of more than 10.6, GCS with a cutoff value of 10.1, if it's less than that, it means it's less than 7, 8, or 6. It's good. And if it's more than that, it's the worst value for that. In conclusion, great technology, gorgeous picture, clinical utility everywhere, everywhere. We have to scratch our mind to look at the clinical utility. And only word I'll say, I hope the stain is no more a stain for. Thank you very much for a patient's here.
Thank you, sir. Thank you for your excellent lectures on a new modalities of echocardiography. Most of us are not using in our day-to-day practice. So you have shown us how useful is this modalities, and almost in all situations, it is much, much, much better. Now, please stay with us. We have now 3-4 minutes left to end the session. So may I invite our chairpersons, our delegates, or any moderators to make some comments or any questions to all speakers, please.
Excellent masterly talk from Dr. Rakesh sir as usual. And it is so important that he has highlighted the value of GLS in our day-to-day practice, which we often tend to ignore. And it is something that we should be looking after the ejection fraction. Thank you so much, sir.
Madam Debika Chatterjee is ready.
Yes, sir. Yes. Now I invite our next speaker, Dr. Debika Chatterjee. She is a senior cardiologist, and she will be delivering her talk. Am I audible?
Yes, ma'am. Yes, please go ahead.
Okay, thank you. Good afternoon, everybody. I'm going to show a few interesting cases of echocardiography. To start with, I will show a few cases of complications of myocardial infarction, which are the leading causes of morbidity and mortality throughout the world. And it is the timely diagnosis and timely intervention that saves the life of the patient. So there, echocardiography plays a great role in identifying the complications of myocardial infarction. So my first patient is 70 years old man, non-diabetic, had severe substernal crushing chest pain 4 days back, and then subsided. And on the day of admission, he suddenly developed severe shortness of breath, and he presented to us with hemodynamic compromise. He was tachycardic, hypotensive, tachypneic, JVP was raised, and there was a systolic murmur over the precordium radiating to axilla. ECG showed ST elevation, inferior valve myocardial infarction, cardiac enzyme was elevated, and he had to be intubated. So when we did the transthoracic echo, the image quality was very poor, but still we could see that inferior valve was akinetic, and the rest of the valves were showing very good contraction. As you can see in the LV in short axis view, and in the four chamber view also. Good contraction. But if we look at the anterior mitral leaflet, it was looking flail. And as I put the color flow in apical 3-chamber view, I got significant mitral regurgitation. The picture quality was pretty bad. To identify the cause of exact cause of MR, where the sensitivity of transthoracic echo is very low, so we did transesophageal echo, where sensitivity is as high as 92 to 100%. So as I did the transesophageal echo in mid-esophageal 4-chamber view, I found that AML is flail with excessive motion. There is a coaptation failure of the leaflets with severe wall-hugging eccentric jet of mitral regurgitation. Now, as I changed the multiplanar angle to around 40 degrees, I could see a large mobile mass is attached to the chordae of flail atriomitral leaflet. And this type of chaotically or erratically moving mobile mass attached leaflet is highly specific for the diagnosis of papillary muscle rupture, and that rupture has resulted in incompetence of the mitral valve because papillary muscles send chordae to both the leaflets, and it is a life-threatening complication of acute MI, though rare, but 50 to 70% of the patients die within 24 hours without any surgical intervention. It is a life-threatening complication because it results, this acute MR results in lethal hemodynamic deterioration. Because if you see, there is a sudden volume and pressure overload in the unprepared LV as well as left atrium. That results in increased LV filling pressure. And not only that, there is a fall of cardiac output also, because large fraction of the blood which is ejected by the LV, it goes back to the LA as regurgitated. So here in papillary muscle rupture, the great role of echocardiography is to identify the cause of mitral regurgitation in this case, because the outcome of the treatment depends on the rapidity of the diagnosis, which we could do very, very quickly. And early surgical intervention gave us a very, very favorable prognosis, and we could save the patient. Another complication of myocardial infarction is here. My patient was 65 years, female, anteroseptal MI. She was thrombolized and she was recovering. And on third day, she developed a new harsh pansystolic murmur. Now, as I did the echocardiography, I could see that there is a scar in the there's a scar. If we look at this this picture, there's a scar in the apical septum, median apical septum, and a dropout in the junction of the healthy myocardium with the scarred myocardium. And not only that, as I put the color flow, there is a flow across that dropout. So this is basically a ventricular septal rupture, which is again another rare complication of acute myocardial infarction with an incidence of 0.2 to 0.3%, and it occurs mostly in the aged female patients with anteroseptal MI. And the time may be accelerated by the thrombolysis, as happened in our case. And this ventricular septal rupture has got a very, very poor prognosis. Mortality is very high, and improvement in survival is possible with early diagnosis, where echocardiography plays a great role, and more aggressive intervention. Traditionally, surgery is the line of treatment, but of late, the device closure is an alternative, attractive treatment, line of treatment, and it is an alternative to surgical repair. As you can see, this is the VSD device sitting very nicely in that particular patient who had a VSD, and there is no residual flow. But again, before putting the device, we need to ensure that the rims of the VSD is adequate to hold the device. If we look here, there was a pretty good apical rim to hold the device in situ, whereas if we look in this particular patient, another patient where there is a ventricular septal rupture, there is no apical rim. So these particular VSD is not possible to close by a device. And next MI complication is we commonly see is a thrombus in the LV, as you see in this case of anteroseptal MI, which happened 2 months back and came for a routine checkup. And when I did the transthoracic echo, the apical 4-chamber view, I could see that there is an akinesia, or we can say dyskinesia, at the apex, along with a discrete echo-dense mass with a well-defined margin, and it is distinct from the scarred myocardium, as you can see. And this thrombus, this is a thrombus, and it is seen throughout the systole and diastole. And this commonly occurs in an anteroseptal MI. And as I have already said, it's located in the region of regional wall motion abnormality, and it should be seen at least in 2 views. As in this case, I have seen in 3 different views: 4-chamber, 3-chamber, and parasternal short axis. And as we know, the size of the thrombus may vary from a very small size, as you can see here, to a very large thrombus at the LV apex in a case of large anteroseptal MI. frequently missed thrombus is the C-shaped mural thrombus, because it is missed because the free concave margin follows the curvature of the LV wall, and it looks like that the thrombus is not a thrombus, it's rather a myocardium, it's myocardium. Well, it is not, it is actually a C-shaped thrombus, which is very, very frequently missed. So we need to see the mass, the thrombus, from off-axis views, and also we need to have a very high index of suspicion to find out this type of thrombus. And the risk of formation of thrombus starts, it might be between, within the first 3 months, or it can be within 24 hours after acute MI. As in this case, we got it within 24 hours. As you can see, this thrombus, the apex is akinetic. And the risk of embolization varies according to the, the line of, whether the thrombus, depending on whether it's organized or not. This thrombus looks quite mobile, so there is a high risk of embolization in this case. And on the contrary, this thrombus is well organized and attached to the aneurysmal apex, where there is no contraction, so the chance of embolization is less in this case. And if we can timely diagnose this type of thrombus and anticoagulate, that reduces the risk of embolization. Now, from the MI complication, let us move to the valve. I'm going to show you some cases of tricuspid valve involvement in mitral valve disease. As you see, this is a case who had BMB a year back for severe rheumatic mitral stenosis with moderate functional tricuspid valve regurgitation, for which nothing was done, and now presented with shortness of breath and ankle edema. If we look at the mitral valve, it's wide open, and if you see here, with a mean gradient of 4, and the valve area was 1.65 square centimeters. As I put the color flow over the tricuspid valve, as you can see here, there is a severe tricuspid valve regurgitation, and this tiny flow is of BMB post the septostomy flow, and this is the severe tricuspid valve regurgitation. The annulus is around 41 millimeter. Yet another case of the mitral valve disease, which was treated with replacement with a mechanical prosthesis, presented with shortness of breath after 5 years with distended neck veins and edema. And shows normal flow. The mean gradient of 3 millimeter of mercury only. But if you see, when I put the color flow in the tricuspid valve, there is a severe tricuspid valve regurgitation. So we see that tricuspid valve regurgitation is quite prevalent in presence of mitral valve disease. More than 1/3 of the mitral stenosis patients have at least moderate tear. And if we leave it untreated, this tear is not resolved even after surgery or BMV, and it reappears. And moderate to severe tear after MVR is an independent predictor of heart failure. So there is a paradigm shift in the current valvular disease management guidelines. More preemptive treatment is done for tricuspid regurgitation, regardless of its degree. Even for a moderate, we take the aggressive line of management. So tricuspid valve is no longer a forgotten valve. It is the most apically placed valve, and we can see the tricuspid valve in transthoracic echo very nicely, and we can identify almost all pathologies of tricuspid valve by transthoracic echo only. So TR in presence of mitral valve disease might be a primary or organic, where there is structural abnormality of the tricuspid valve, and it occurs only in 15 to 30% of cases. Whereas secondary or functional TR where the leaflets are normal and the tear is due to the annular dilatation occurs in most of the patients. So if we look here, in this case, if we look at the tricuspid valve leaflets, the leaflets are structurally normal. It is the annulus which is dilated and leading to the coaptation failure. So this valve is ideal for ring annuloplasty in the tricuspid valve along with the mitral valve replacement because of the MR. Whereas if we look at this patient, the mitral valve shows stenosis, and look at the tricuspid valve. Tricuspid valve leaflets are thickened, shortened, stenosed, and there are deposition of calcium and color flow show tricuspid valve regurgitation along with forward flow stenosis. So this is basically a primary organic tear. This is not suitable for tricuspid valve annuloplasty. It needs mitral valve replacement as well as the tricuspid valve replacement. So the relevant, surgically relevant echo information which we need to give regarding the tricuspid valve are its anatomy of the leaflets, whether they are thickened, restricted motion, which need replacement, and then next is the annular diameter. If there is a functional tear, the annulus will be dilated, leaflets will be normal, so that is suitable for the repair. And also we need to look at the RV function for the prognosis of the patient. So if we can give this surgically relevant echo information properly, a surgeon can really repair the valves. As you can see in this case, both the mitral valve and the tricuspid valve were repaired with annuloplasty. As you can see, these 2 points with no residual MR or tear. So this is high time that we look at the tricuspid valve properly, and it is no more a neglected or neglected valve. Now, let us see some other cases where we have used three-dimensional echocardiography. Here is a patient who is 45 years old, female, presented with shortness of breath, and on auscultation, there was a hollow systolic murmur. Now, with transesophageal, two-dimensional transesophageal echo, I could see there is a prolapse of one of the scallops with significant MR. As I change the angle of the multiplier angle, I could see prolapse. I could see the prolapse. I was not very sure whether P2 or P3. I was not very sure whether it was P2 or P3, but there was severe mitral valve regurgitation. But as soon as I did the conventional transesophageal echo, where it was a realistic representation of the mitral valve, showing the AML at the top and PML at the bottom, and I could see the entire mitral in a single screen display. And I could see that it was not the P1, not the P2 scallops of the posterior mitral leaflet. It was the P3 scallop, as you can see, which was prolapsing. And the cause of the prolapse was a caudal rupture. As you can see here, there was a caudal rupture which was causing the P3 scallop to be prolapsed. So this is a surgically repairable valve. Thus, we see that three-dimensional transesophageal echocardiography of mitral valve is a common language between the imaging cardiologist and the interventionist. If you compare with this model, this mitral valve is the on-first view or the surgical view of the mitral valve, where aorta is at 12 o'clock position and LA appendage on the left-hand side, AML at the top, PML at the bottom. And here is, with the help of three-dimensional echocardiography, I'm going to show a complication of prosthetic mitral valve. This is the bileaflet prosthetic valve done 1 year back, presented with shortness of breath on auscultation, normal click, but there was a pansystolic murmur. In transthoracic echo, I could see there is a dehiscence on the outside the sewing ring with some regurgitation. To confirm the diagnosis of this regurgitation, I did a transesophageal echo where I could see this is the bileaflet prosthesis, but outside the sewing ring there was a gap, echo dropout, and with the color flow, large regurgitation. So this is basically paravalvular leak or paravalvular regurgitation, which is a complication of the valve replacement because of the inappropriate sealing of the sewing ring to the native tissue, and it is more common in the mechanical mitral prosthetic valve. Most of these paravalvular leak are incidentally detected during the follow-up, and they remain clinically, hemodynamically very insignificant, and a benign course. They take a benign course, but around 5% of these cases are large. These paravalvular leaks are large, and there is clinically significant mitral regurgitation. Those are the cases which need to be closed. Traditionally, again, surgery has been the treatment, treatment of choice, but of late, percutaneous device closure with the VSD device is an attractive alternative. But when we do this percutaneous device closure, sizing of the paravalvular leak is very important, very crucial, because interventionists choose the size of the correct device from sizing of the PVL. Now here, if we measure the PVL, it measures around 5.4 millimeter. Now the question is this the true size and shape of the PVL? Because it will be true if it is cylindrical in shape. But often these paravalvular leaks are crescent shaped or serpiginous in shape. So there comes the role of three-dimensional transesophageal echo, which is a preferred imaging modality to know the morphology of the paravalvular leak. Here you can see this is the prosthesis and the sewing ring. You can see the stitches over the sewing ring. Two discs are opening normally, but if you look outside the sewing ring, this is the paravalvular leak, which is causing severe MR. And if you look at the leak, it is crescent shaped. It's not at all cylindrical. So it helps to choose the correct size and size of the device. And not only that,
could you please conclude, madam?
Hello?
Could you please conclude?
Okay, one more slide. So by turning the picture up, by around 90 degrees, if we can bring the this leak at, aorta at 12 o'clock, then we can say that this is at 11 o'clock position, and it is very, very convenient for the interventionist to come with a device and close it, and I can show with the 3D echo. I can ensure the adequate positioning, and then the device can be released, and look at the result. There is no mitral regurgitation. It is totally closed. Okay, there are more cases, but since time is out, I'll stop here.
Thank you, madam, for great lectures, and you have beautifully demonstrated various abnormalities picked up by echo and how it helped us in making a decision, therapeutic decision. This was a great lecture. Congratulations, madam. Thanks. From organizing team. Thank you, madam. Thank you. Ashish Sinha, you want? Or any comments from the expert speaker?
You are muted, Dr. Ashish, you are muted. Please unmute yourself.
Yeah. Hi. Good afternoon, everybody. I actually joined a little late, but I was really happy to hear about the topic on GLA. And this is something which we are not doing it on regular basis, but I think now we should be doing it and help others also. So the importance of tissue doctor and GLA is something which we have. Thank you. It was a great lecture.
So and so forth, which are listed in the slide. it seems that if you compare the incidence from the 90s until the early 2000s, there seems to be a gradual and steady decline in the incidence of this first 24-hour incident of the mortality, and people seem to have tread and crossed along that line. However, that may not be translated into cerebral organ outcomes positively and discharges.
Doctor,
okay,
may I ask?
Coronary heart disease is a predominant cause of.
I think we are hearing from all A.
On A, okay. No, may I ask one question to Dr. Ranjan Kumar on CT scan angiography? What is the cutoff of heart rate where you can go for CT scan angiography? And what are the limitations? In many situations, we cannot do CT scan angiography. Can you give us a take-home message when not to do CT scan angiography?
What we know already can be translated to
Dr. Ranjan Kumar.
Yes, am I audible, sir?
Yeah, now for our physicians friends, can you give us a take-home message in very short, just in 1 minute?
Regarding heart rate, sir, we are now doing till 80 heart rate, but if it is around 70 or 65 to 70, then it is better for us, sir.
In presence of a stent, how useful is this CT angio to pick up the lesion? In a stent restenosis, how useful it?
Sir, it's very useful, but only limitation is that the stent diameter should be equal to or more than 3 millimeter. Because less than 3 millimeter, there is limitation. We cannot see the lumen very well. So otherwise, more than 3 millimeter, CTCS is excellent doing or assessing the stent patency, sir.
Madam Mona Bhatia, madam, since the cardiac MRI is not available in everywhere, so can you summarize what are the absolute indications for cardiac MRI in day-to-day practice? When should we really go for cardiac MRI in some of the important situations? Because it's not available.
I think it's very variable because one is in our hospital, even myocarditis, whether it's post-COVID or it's pediatric, little children who come with DCM, it's almost like an emergency MR to look for myocarditis so that they can be given the ICT earlier in the stage of the disease. So one is like the myocarditis. Then we have a lot of cases of post-TOF repair where we're looking at RV function. That another thing where you really want the gold standard RV function. Hypertrophs is another situation where in order to prognosticate these patients, you need to have the extent of scarring evaluated. So I think these are three places where a lot of requirement is there. And then you always have the dilated cardiomyopathies where whether it's TB sarcoid, because a lot of these patients have been treated as idiopathic DCMP. So I think it's only fair that they at least have a diagnosis to them and understand, because we have a lot of these in our country which are infectious. And if you have sarcoid, at least you can give them the steroids.
I'd like to ask one question.
From my point of view, Dr. Bhatia, we generally would like to take a decision on whether to offer this patient an ICD or not give it an ICD. And the other situation is when you want to decide upon the viability and you want to intervene or not. So these are the two situations where I would say that I would recommend an MRI. It is not widely available in a center, where I want to decide whether I want to revascularize or not, and where I have to decide whether this patient is going to benefit from an ICD or not.
Thank you, sir. Totally agree.
The last question, Dr. Ashish.
That is what I just wanted to know, because for viability post-MI, suppose the lesion is LAD is occluded or some vessel is occluded. So for viability, what do you prefer, a nuclear scan or a cardiac MRI?
See, I prefer the cardiac MR because I think it gives a lot more information. It gives you your function, it gives you your, your transmurality, extent of scar, everything. So I think the extent of evaluation that you get out of a cardiac MR is more than what you get out of nuclear.
Yeah, this is becoming one of the most common indications for MRI, because there are so many MI patients who are coming late and they have occluded vessels.
Dr. Ashish, can I have your views on the CT FFR that we are not looking at?
Please unmute. Ashish, please unmute.
Yeah. Thank you so much, sir. The point is that I don't do CT, so I don't have much of experience on that. So what FFR, what we do is in cath only. But I think I won't be able to explain on the CT FFR much as
Dr. Bhatia.
I can tell you that CT FFR I think is a really great potential tool, and I think a lot of the work will now move to CT because you have the entire coronary assessment, stenosis, plaque assessment, plaque burden. You can look at myocardial perfusion. You can look at scar imaging because now if you have the dual source CTs, and you can have the FFR. So if you have this entire gamut, you have this one-stop shop. So I have a feeling a lot of the work will go from even MR to CT. And the CT FFR is now evolving into a very, very robust tool. So definitely an excellent tool at this point.
Okay, definitely.
I'm sorry to say we are running behind 5 minutes. So with code of my heart, I thanks all the speakers for their brilliant talks and all the participants. We congratulate each of you, and we will meet you soon, in next year. Thank you very much. Thank you.
This year, Hyderabad not coming.
Yeah, Hyderabad. Okay, definitely Hyderabad. But in Bihar CSI, we will definitely would like to see your faces in the next year.
I only want to make a comment that I think Dr. Narayan's lecture just stole the show. It was the most incredible lecture I've heard in many years, and nothing beat it. Like Sehgal versus whoever, it was the classic lecture of all times.
Thank you, madam.
Thank you, madam. All the lectures were so informative. I gained so much listening to you all. Thank you very much.
So with permission, I'm just closing this session. Thank you very much.
Thank you, sir.
Thank you, sir.